Hello everyone. So we are continuing our discussion on abortion, and in second trimester abortion, we have the most common cause, one of the most common cause, that is cervical incompetence, and that is also known as cervical insufficiency. So talking about causes of cervical incompetency, the retentive power of cervix internal os may be impaired functionally and or anatomically due to the different condition like congenital uterine anomalies and acquired iatrogenic condition like in the following the D and C operation, endosuppression by dilation and evacuation, vaginal operative delivery through an undilated cervix, the amputation of the cervix or cone biopsy, trachelectomy or loop excision of cervix, and other like multiple gestation, prior preterm birth, and cervical incompetence is considered as a biological continuum of spontaneous preterm birth syndrome. The diagnosis of cervical incompetence is made by the history, that is by recurrent mid-trimester painless cervical dilation. The recurrent mid-trimester painless cervical dilatation without apparent cause and escape of liquor amni followed by painless expulsion of product of conception are very much suggestive of cervical incompetence. So internal examination, in the pelvic examination, the interconceptional period, bimanual examination reveals presence of unilateral or bilateral tear or gapping of the cervix up to the internal os. And investigation in the interconceptional period include passage number 6 to 8 Hagar dilator beyond the internal os without any interresistance, and pain and absence of internal os snap on its withdrawal, especially in premenstrual period, indicate incompetence. The premenstrual hysterocervicography shows funnel-shaped shadow. The internal os is supposed to be tight due to action of progesterone during this phase of cycle. Similar funnel-shaped shadow may be found if hysterography is done in proliferative phase, even with competent cervix. So, in premenstrual hysterocervicography, this shows a funnel-shaped shadow. So, as we can see in this picture, the diagnosis of incompetent cervix. The incompetent cervix showing the funneling. This is the funneling. Incompetent. This is cervix. Incompetent funnel. It shows the funneling. You can see the funnel shaped, and you can see a B. This B picture number B is the ultrasonographic view of normally competent cervix, T-shaped. Normally cervix is T-shaped. This is normal, and it shows the ultrasonographic view of incompetent cervix showing V-shaped funneling, and it is ultrasonography view of incompetent cervix showing funneling U-shaped, V-shaped, and this is ultrasound of normal cervix. This is normal, this is fetal head, and it show the T-shaped. So that was. And the diagnosis during pregnancy include the clinical speculum. There is painless cervical shortening and dilatation. The sonography shows a short cervix less than 25 mm, funneling of internal os more than 1 cm. Incompetent cervix may appear Y-shaped, V-shaped, U-shaped, and the speculum examination shows the detection of dilatation of internal os with herniation of membrane. And talking about investigation for recurrent miscarriage, the thorough medical, surgical, and obstetric history with meticulous clinical examination should be carried out to find out the possible cause, as mentioned previously. And so the careful history taking should be include the nature of previous abortion process, histology of placenta, karyotyping of conception if available, if any chronic illness, and diagnostic tests like blood glucose, fasting and postprandial, the BDRL test, thyroid function test, ABO and RS grouping of husband and wife, the toxoplasma antibody, IgM and IgG, autoimmune screening, lupus anticoagulant and anticardiolipin antibodies, serum luteinizing hormone on D2, D3 of cycle, ultrasonography to detect congenital malformation of uterus, polycystic ovaries and uterine fibroid, hysterosalpingography in the secretary phase to detect cervical incompetence, uterine synergy and uterine malformation, This is supported by stereoscopy and laparoscopy or MRI. The karyotyping of the husband and wife, and the endocervical swab to detect chlamydia and mycoplasma and bacterial vaginosis. And now we are finally moving on to the treatment of the recurrent abortion. In the interconceptional period, there should be counseling should be done to alleviate anxiety and to improve psychology. While counseling the couple, there should be assured that even after 3 consecutive miscarriages, the chance of successful pregnancy is very high. That is more than 70%. So, however, the success rate depends on underlying etiology as well as age of women. So, the patient should be reassured. And the hysteroscopic resection of the uterine septa, synechi, and submucous myoma improves the pregnancy outcome. The uterine unification operation like metroplasty is done for cases with bicoordinate uterus. And the chromosomal anomalies, like if chromosomal anomaly is detected in couples or in the abortus, unbalanced translocation, genetic counseling is undertaken. Couples with the chromosomal translocation or inversion are counseled for pre-implantation genetic diagnosis. If the defect is parental, the artificial insemination of by the donor is advised. For a maternal defect, donor egg may be fertilized by the husband's sperm. The pre-implantation genetic diagnosis is also available for parents who wish to use their own gamete. And for women with PCOS are best treated for their insulin resistant hyperinsulinemia and hyperandrogenemia. Metformin therapy is also useful. And the endogenous dysfunction, control of diabetes and thyroid disorder is also. The subclinical diabetes and thyroid disease may be treated with if no other factor is present. The genital tract infection are treated appropriately following culture of cervical and vaginal discharge. And empirical treatment with doxycycline and erythromycin is cost effective in the genital tract infection. And during pregnancy we have to do again reassurance and the tender loving care TLC are very much helpful. Probably this removes the stress and improves the uterine blood flow. And we have to do ultrasonography should be used at the earliest to detect the viable pregnancy. This will influence the further management. If the fetus is viable ultrasonographically at 8 to 9 weeks, only 2 to 3% are lost thereafter. So similarly fetal loss is only 1% after 16 weeks of viable fetus. So that's why USA is important. And the rest, patient should take adequate rest and avoid strenuous activity, intercourse and traveling. And in the progesterone therapy, in case with luteal phase defect and recurrent miscarriage is given with natural micronized progesterone 100 mg daily as vaginal suppository. It is started 2 days after ovulation. Once pregnancy is confirmed, the progesterone supplementation is continued until 10 to 12 weeks of gestation. Progesterone is necessary for successful implantation and continuation of pregnancy. So this is due to immunomodulatory load. It induces pregnancy protective shift from pro-inflammatory TH1 cytokine response to more favorable anti-inflammatory TH2 cytokine response. And benefit of HCG therapy in current miscarriage are not established, and HCG stimulates corpus luteum to produce progesterone. So progesterone therapy, natural micronized progesterone or mg daily. Okay. Then we have for the antiphospholipid antibody syndrome, the women are treated with low dose aspirin of around 80 milligram per day. 80 milligram per day, low dose aspirin 80 milligram per day, and heparin is we should give heparin 5000 units subcutaneous. Heparin we should give 5000 units subcutaneous twice daily up to 34 weeks. The unvaccinated heparin and low molecular weight heparin are equally effective and safe. Now we have the circlage operation. Circlage operation for cervical incompetence is to be performed, and the chromosomal error if the defect is parental, artificial insemination by donor is option. For maternal defect, donor egg may be fertilized by husband's sperm. The PGD is also available for patients who wish to use their own gamete. The pre-implantation genetic diagnosis in gastromere stage is another option. Only then the few balanced embryos are transferred and then successful pregnancy. And next one is immunotherapy. Any form of immunotherapy is no longer used, and this is no longer used. And the inherited thrombophilia's antithrombotic therapy improves the pregnancy outcome. We said you have to use the heparin 5000 international unit subcutaneous twice daily, or low molecular weight heparin, enoxaparin subcutaneous once daily is preferred, is effective. Heparin is given for 34 weeks. And for medical complication in pregnancy, hemoglobinuropathies, SLE, cyanotic heart disease are advised to delay pregnancy until the disease is optimally treated. During pregnancy, specific management is continued. And unexplained, despite the different investigation, about 40 to 60% of recurrent miscarriages remain unexplained. However, tender loving care and some supportive therapy improves the pregnancy outcome by 70%. So for management of cervical incompetence, we have to do the two operations. One, we have the circlage operation. We have the circlage operation, and next we have the McDonald's operation. The details about this operation is not so important at this our level. So talking about prognosis of recurrent miscarriage, the prognosis of recurrent miscarriage is not so gloomy as it was previously thought. The overall risk of recurrent miscarriage is about 25 to 30%, irrespective of number of previous spontaneous miscarriages. The overall prognosis is good even without therapy. The chance of successful pregnancy is about 70 to 80% with effective therapy. The reassurance and tender loving care are very much helpful. So that was all. So that was all about recurrent abortion. Now from next video we will talk about medical termination of pregnancy, MTP. Thank you.